the outset, I would like to thank all of you. I know your tea break has been cut short. So really appreciate that, you guys are genuinely academically inclined, and that's why you're still here. I hope we do justice to this session. And I would also like to thank the organizing team of Life Conference for this wonderful opportunity. Thank you, ma'am. My topic is a little different. This is ART after fertility conservation treatments in gynecological malignancies. Very refreshing. Again, an interesting perspective and a very positive attitude, because over the past decade, we have seen how oncofertility is being developed. And earlier, we were talking about, can we do fertility preservation? How do we do fertility preservation? Now we have reached the stage where we are talking about what to do when these women survive. And this is just a repetition. Dr. Somsekhar has already spoken about this. Incidence of cancer is rising. Again, breast cancer has now overtaken cervical cancer, even in India. And mortality also is beginning to go low. In India, the scenario is the same. Breast cancer is about 1/4 of all the women who do diagnose with cancers. And of course, ovarian and cervical cancers there. With the change in lifestyle and epigenetic modifications, there is an overall increase in the risk of developing cancer during our time now. About 45% of men and 37% of women do have a risk of having cancer during any point of time in their lives. This risk increases with age in both the sexes. 1 in 72 men and 1 in 51 women under the age of 39 years are also at a risk of having cancer. So what happens then? Of course, with the advent of new technologies, the survival rates are getting better. These numbers are increasing, one, because our diagnostic techniques have improved, and second, the management has become far more proactive and scientifically advanced. And that's why you can see even in the breast cancer now, the survival rates have gone up to about 90%. And therefore, the need for fertility preservation in this set of women. Before we move on, let's just remember that fertility preservation is also done for non-oncological conditions like autoimmune diseases, hematopoietic stem cell transplantation, and other medical conditions where we anticipate that the ovarian insufficiency might set in. Why does that happen? With cancer, there could be an impact of the surgery which is done for the cancer, or the chemotherapy or the radiotherapy that is given for the cancer prevention and management. Radiation therapy, we all know if it's given in the local area, that means for the cervical cancers, the uterus does have hampered blood flow. Also, cervical surgeries can increase the risk of miscarriages or early preterm deliveries. Chemotherapy, we all know the gonadotoxic effect of the alkylating agents. Apart from that, even as anthracycline chemotherapy can damage the heart, which does get impacted later on during pregnancy. GnRH analogs, which was promoted very heavily, I think about 8 to 10 years back, as a preventive mechanism for women undergoing chemotherapy or radiotherapy, now with the evidence says that it really may not impair the results with the ovulation, the cycles, and the ovarian insufficiency itself. This is again a very interesting paper that has come. Dr. Puneet Arora has already discussed quite in detail about the impact of cancer on the egg reserve, so I won't go into detail, but this is a paper now in press where they have compared the cancer survivors versus their age-matched controls, and they've seen that there is actually a decrease in the AMH, AFC, also the FSH does increase. So in all, what that means is that, yes, there is going to be a decline in the egg reserve of a woman who undergoes cancer. Again, like you rightly said, ma'am, it could be the biology itself. Now, how do these impact? Again, this is another paper that came out way back in 2013, which clearly said that after chemotherapy, there is going to be a decline in the egg reserve. Radiotherapy, we all know, is a known cause of ovarian insufficiency. A single dose or the fractionation of doses will cause the damage based on how much is given. Up to 6 grays itself is enough to cause a complete depletion of the ovarian reserve. And let's not forget the damage that it has on the endometrium as well. So even though the endometrium might look all right, there is a dysfunctional endometrium that can happen. There are double-stranded DNA breaks which do cause irreversible cell damage. And pelvic radiotherapy, especially given for pelvic malignancies like cervical cancer, do damage both the ovaries and the uterus. So what do we do? Now the woman was diagnosed with cancer, she has been treated. What should be the next step? The next step is obviously hope, because we know that the survival rates have gone up, and therefore we need to understand who to offer this fertility preservation therapies to. The age of the woman, the obstetric history, the desire of the patient to even retain fertility has to be addressed. The type and the extent of cancer, what is her overall prognosis? We do get some inquiries for patients who are stage 4 cancers, and they say, no, she's just 20, just save some eggs, just do something. I think we have to be judicious about it. In the morning, we had a wonderful session where they were talking about paternalism. I think as doctors, we need to know when to say yes and give hope and when to stop it as well. Again, the risk of sterility with the proposed treatment has to be looked into. For the fertility preservation, the major concerns are the time available for the cancer treatment. Any oncologist, oncosurgeon, or for that matter, even the patient's family would not want to wait 15 days. That requires intensive counseling. Therefore, counseling from the first stage, from the counselor to the oncosurgeon to the gynecologist, very, very important. We need to work together as a team, understand what's the time available and what's the treatment we can offer during that time. There are potential risks of delaying chemotherapy, which has to be borne into mind. So we shouldn't go over aggressive and saying, you know what, just give me 3 weeks, and then you may end up spreading the cancer at that point of time. There is an impact of hormonal stimulation on the tumor, which has to be remembered. Like Dr. Puneet already spoke about keeping the estrogen levels low during stimulation, we have that knowledge with us now. The possibility of tumor contamination of the harvested tissue, especially if we are doing ovarian cortex cryopreservation or ovarian tissue cryopreservation or ovarian cryopreservation, has to be borne in mind before we go ahead and transfer it back. There is also an impact of future pregnancy on tumor recurrence, which we need to address. This just doesn't stop there. I had a patient who walked in who said, all right, fine, doctor, everything's fine, you're going to freeze my ovary, whatever, the tissue. I'll get pregnant. How can you assure me my child will not have cancer? So that's again something which requires a lot of counseling, genetic profiling of the patient, and also they need to understand that there is an emotional stress which is associated with coping with the uncertainty as to what will happen. But having said all of that, fertility preservation is the need of the hour. It can help women have children or even go for the second or third child and complete their family even after cancer treatment. This is the ray of hope which probably helps a lot of women to even continue with the cancer treatment, knowing that there is hope at the end of the tunnel and they might actually complete their families later on. Again, this requires teamwork from the counselor to the gynecologist to the oncosurgeon, reproductive medicine specialist, and a radiation therapist. What are the cancers? This is just to brush up to remind you what are the gynecological cancers we're talking about. What cancers we can salvage and do fertility preservation for is the cervical cancer, stages 1, ovarian epithelial tumor cancers. Borderline ovarian tumors are the ones which are most commonly seen, and now the awareness amongst even surgeons is rising as to saving the oocytes or the ovarian cortex. The endometrium, having the endometrioid cancer. So again, these are the various options which are available. Sorry for the busy slide, I don't know if you can read it. We first understand that there is a diagnosis of the cancer. We need to get the approval from the oncosurgeon, understand the prognosis, see the age, see her AFC, if she's under 40 with a decent AFC, and requires this treatment and has been given an okay by the consultants, we can go ahead. Again, the risk of reducing or losing the ovarian reserve with treatment has to be assessed. There are some cancers which do not impact the fertility, and at that stage, probably for a woman to recover and come back to us for treatment would be more sensible. The various techniques depend upon the woman's pregnancy desire, the age, the type of tumor, the stage of disease, the type of surgery, and the adjuvant treatment which is given. For cervical cancer, I'll go a little bit more into the details of what happens after we do these surgeries a little bit later. But just to recap, for the cervical cancer stage 1, there could be conization, simple trachelectomy, and neoadjuvant chemotherapy. For endometrial cancer, it's usually progesterone therapy or surgical resection. For ovarian cancer, for borderline tumors, just one side oophorectomy or adnexal resection with conservative surgery and adjuvant chemotherapy is usually offered. So what can we do at that stage and after that? The technique again depends on the age of the patient, the type of the patient, the treatment which is offered, the time that's available to us, and the likelihood of the ovarian metastasis of the tumor. We could offer them oocyte or embryo cryopreservation, ovarian tissue cryopreservation, in vitro maturation. Now, the recent technology is all about primordial and preantral follicle cultures as well, and of course, uterus transplantation and ovarian suppression and agonist therapy. So if you look into this slide for the cervical cancer, after the radical trachelectomy, there has been spontaneous pregnancies in up to 70% of women, though the risk of second trimester loss is a little more. Again, for borderline ovarian tumors, stage 1 by FIGO, there is unilateral oophorectomy. With that, following that, there is a favorable outcome which has already been documented. However, let's not forget that there is a risk of about 20% of recurrence. So the patient has to be adequately counseled. For epithelial tumors, they're a little more aggressive. So as of now, ESHRE says to be on hold as far as the epithelial tumors are concerned. But yet, even after epithelial tumors having removed and complete cancer treatment being done, these women have been noted to have pregnancies. For the endometrial adenocarcinomas, there is hormonal therapy, following which the endometrial biopsies are done every 3 months. Once the woman is diagnosed to be clear from the cancer, pregnancy can be attempted. We have got many pregnancies in women who have come to us with endometrial hyperplasia or even stage 1 adenocarcinomas. But again, let's not forget the recurrence rates are there and the patient has to be adequately counseled. I've already discussed about the various options available, which is oocyte cryopreservation, that means freezing the oocytes, embryos if the patient has a partner, the ovarian tissue cryopreservation and transplantation, which is now becoming more popular and changing its status from just being experimental. So this is again, just to recap, the various modalities in which the ovarian tissue or the cortex can be cryopreserved, or the primordial follicle can be retrieved, or just the oocyte can be frozen, or the embryo could be frozen. And once the patient's done with the cancer and she comes back cancer clean for a few years, these oocytes can be used by assisted reproductive technologies, and she does have the chance of having a healthy baby. This is the recent article come out this year. This is actually an 18 years experience which was out in 2019, this year itself, which says that offering fertility preservation is no longer considered optional, and it must be included in every therapeutic program for women who receive an oncological diagnosis in their reproductive age. This is, again, a very motivating research and a very interesting papers with 18 years of their data, where they do see that women have survived cancers, have come back, and have babies out of their own embryos or oocytes which were frozen. So this was way back in 2017, where they did mention the different kinds of techniques which were used for fertility preservation. And in the first study, they had about 54 cancer patients, where 33 did come back, and they had a live birth rate of about 22%, which is fairly decent. And the other study, they had about 18 who returned back, in which they ended up having a 45% live birth rate. Some techniques, some fertility preservation techniques were by oocyte vitrification, and ovarian cryopreservation itself, in about 111 cases, 32 have conceived. So this is no more just scientific talking in conferences, but this is actually a reality. And we should, as obstetricians and reproductive medicine consultants, counsel our patients adequately and counsel our fellow oncologists and radio-oncologists as well about the options which are available. So in ART, we know that we need to start by collecting the eggs, making embryos, and going for transfer. Dr. Puneet has already discussed about the various protocols, so I don't need to get into that. This is an interesting paper where they compared actually the frozen embryo transfer rates for women who did have cancer with the ones who did not have cancer. And the live birth rate of about 38% was seen in non-oncological patients, and 37% was seen in women who did manage to survive cancer. So again, we can see that the research is now telling if a woman is pulled through cancer, everything's fine, we can give her the ray of hope. There are just a few do's and don'ts, like keeping the estrogen levels low. So this COSLS is again using controlled ovarian stimulation with letrozole supplementation, especially for breast cancer, because we want to keep the estradiol levels low. Again, in fertility preservation for endometrial cancer, there was a lot of debate on that, but yes, the current recommendations do say that in grade 1 minimally invasive tumors, it can be offered. The important thing is to understand what is the tumor's pathology, biology, what is the myometrial penetration, and choose the optimal approaches for fertility sparing even before we come to doing the embryo transfer. But what about the steroid hormones? Because that's the common fear where when we talk about fertility preservation with oncologists, this is the common worry they have. What do steroid hormones do? Yes, estrogen does have an impact on gynecological cancers, but again, what is the impact? Is it really so bad? So there is a little bit of controversy here as well. Those sex hormones are the most potent carcinogenic hormones. Again, the hormonal therapy with both progestin and estrogen will increase the risk of ovarian cancer. However, contraceptive pills may have a protective effect in women with increasing parity compared to older women and women who have never used contraceptives. But these are all very small studies, so do we really address this, or we just wait for that? So that's the controversy there. Now again, breast cancer, a lot of talk has happened, so I won't go into the details, but just to tell that about 70% of those cases are estrogen receptor positive, and they do tend to have a high relapse rate. So therefore, make sure that the patient has pulled through the stages before we start her pregnancy planning. Again, in endometrial cancer, there are about 90% of these cancers have estrogen receptors. So when we are planning embryo transfers or stimulation, the estrogen level has to be kept low. Ovarian cancer, there is an increased relative risk of only about 2.2 to 3%, depending on the continuous estrogen usage. So actually, estrogen is supposed to be protective against ovarian cancer. But the germ cell tumors or the endometrioid or histological type of cancers have to be looked into. So this was presented in this year's ESHRE, where they did say that germ cell tumors will have about 5 to 10% rate of infertility, and we can offer embryo oocyte cryopreservation even for germ cell tumors. Of course, ovarian tissue cryopreservation and bilateral oophorectomy and retaining the uterus for just using donor oocytes but giving her a self-pregnancy are also options. Now, the recommendations from ESHRE say that in epithelial tumors, pregnancy should be fast. After the delivery, the other ovary can be removed. For borderline tumors, pregnancy usually is followed by a spontaneous delivery. And for the germ cell tumors, ideally wait for 2 to 5 years and then plan a pregnancy. So now that we've got the embryos, the question that the family or the patient might ask us is, how do you know that ART is not going to impact on malignancy? There is not a lot of evidence yet, because again, oncofertility is a very recent subgroup of reproductive medicine, but there is no evidence that says that ART influences endometrial cancer or cervical cancer. Ovulation induction does not appear to be associated with an increased risk of relapse, and subsequent pregnancies do not lead to worsening of pathological outcomes. Now, what about endometrial carcinoma? This is where the controversy is. The ovarian stimulation drugs will raise estradiol levels, and clearly this endometrium is hormonal sensitive. Are we going to flare up? So here the best option is to go for natural cycle or letrozole-based modified natural cycle protocols for the endometrial preparation. Again, the ovarian stimulation drugs, there have been studies which don't give clarity. They do say that there is a twofold increase in endometrial cancer with usage of clomiphene and HMG, and then there was another study which said that actually there isn't a very significant increase. Likewise, the same thing for ovarian cancer. Do ovulation induction drugs cause cancers? Lot of studies that say yes, and lot of them that say no. So we have to be judicious and understand and treat each patient as a personalized ovarian stimulation. Now for borderline tumors, clomiphene citrate, HMG or FSH and analogs do not really increase the overall risk of ovarian tumors. Just 2 minutes. And the risk of ovarian cancer is more likely in current hormonal therapy users as opposed to women who have taken it prior. So what about the risk of transferring the malignant cells? Again, there have been 5 cases of ovarian tissue autotransplantation where they have not found any signs of relapse from the grafted tissue. Of course, this is done meticulously by doing immunohistochemistry and understanding that there is no evidence of cancer in the tissue which is being put back. So early stage endometrial cancer again has a very low risk of metastasis. Now ovarian transposition, the only practical difficulties which may happen once this was done is the access for oocyte collection. And a transposed ovary, which is actually located in the paracolic gutter, is likely to be inaccessible for a safe oocyte retrieval. Now that the woman's got pregnant and she's survived cancer and she's got those embryos back, what do we do for the pregnancy? Eggs that have been exposed to chemotherapy or radiation may have been managed or damaged, so we need to clearly explain about the risk of having miscarriages. Also, the recovery from treatment and its effects have to be explained to the patient. Adequate counseling and informed consent is mandatory. Clearance by the oncologist for an acceptable period of time in which the recurrence is not likely has to be very clearly understood. Also, the ethical issues and moral dilemmas need to be addressed, which means what happens to these embryos if the woman dies, whose property are they, and so on and so forth. Again, this is a recent evidence that talks about the recommendations by the fertility preservation guidelines that say that women who have had cancer treatment should be counseled that they may have a shortened reproductive lifespan and therefore they should be offered fertility cryopreservation. And pregnancy after cancer treatment should be managed as a high-risk pregnancy in a tertiary care unit. After breast cancer, we ideally need to wait 2 years. Again, a study says that even after 6 months of treatment, there is no risk in having a pregnancy. And a lot of proportion of these women do end up having some amount of congenital abnormalities, which were all old studies that came out, but now the data is changing. Now, can pregnancy influence breast cancer recurrence? Again, the impact of pregnancy on the prognosis of breast cancer suggests that women who did get pregnant after breast cancer actually have a better overall survival as compared to women who did not. So that means pregnancy is actually protective in some way. This is the SRM guidelines that say for uterine cancer, endometrial cancer stage A, conservative surgery after medroxyprogesterone treatment may be the new treatment option for women who aim to preserve. Now, a quick note about cervical cancer. Yes, we all know trachelectomy is a mode of treatment, but what happens after trachelectomy? There is clear evidence that yes, there is second trimester pregnancy loss, premature delivery, and therefore once the patient is pregnant, she needs to be carefully followed for cervical incompetence and other risk factors like premature rupture of membranes. However, it is reasonable to counsel women to avoid pregnancy for at least 6 months after trachelectomy, both in view of large volume or totality of the cervix that has been removed and to enable confirmatory evidence for absence of disease or any early recurrence. Now, for us as reproductive medicine consultants, the only thing that might be different in a woman who's undergone trachelectomy is that number one, we should not transfer more than one embryo because we don't want multiple pregnancies as the cervix has been shortened. And very rarely, there might be a need for transmyometrial embryo transfer as well. Labor could be complicated in such women, and therefore that has to be borne into mind and the patient has to be adequately counseled. So these are the guidelines. This was a wonderful website on I had cancer and a lot of hopeful messages from cancer survivors, which I want to leave you with. So yes, fertility preservation is here to stay and it's a ray of hope. And every mother deserves to have a baby wearing that t-shirt, I guess. Thank you so much for your patient hearing.